Good morning. I'm Isobel Mackenzie, Seniors Advocate for the Province of British Columbia. First, I would like to acknowledge that we are gathering on the traditional territory of the Lekwungen-speaking peoples of the Esquimalt and Songhees First Nations. The past 18 months has seen British Columbians challenged as never before, and we have met this challenge with courage, compassion, and commitment. Across the province, people have been making sacrifices to keep themselves, their loved ones, and their community safe. COVID-19 vaccination rates in BC are some of the highest in the world. I think we're about 82+% of people fully vaccinated. And we're doing all we can every day to combat this pernicious and prolific COVID-19 pandemic. First, I would like to express condolences and deepest sympathy to the families who have lost a loved one in care during the COVID-19 pandemic. This past year has brought sacrifice and heartache to our already fragile healthcare system. However, we also witnessed tenacity, commitment, and opportunity to use what we have learned to improve long-term care and assisted living for the future well beyond this COVID-19 pandemic. It is very clear that British Columbians care deeply about the health and well-being of its oldest citizens, and this, more than anything, gives us hope for tomorrow. Now, while we have all been affected by this pandemic, it is seniors, particularly those who live in long-term care and assisted living, that have felt the deepest personal impact, as they are so disproportionately at risk of serious illness and death from COVID-19. Long-term care and assisted living staff and residents were 3.5 times more likely to contract COVID-19, and residents of long-term care were 32 times more likely to die from it. This burden was further compounded for residents who endured long periods of separation from their loved ones, for staff who are exhausted physically and mentally from working under unimaginable stress, for care home operators who saw exponential growth in the workload related to managing all aspects of their facilities. This report is looking back and examining some of these experiences in the context of the outbreaks during what we traditionally call Wave 1 and Wave 2 of the pandemic. This report was possible because of the extraordinary efforts of staff, operators, Health Authority and Ministry of Health and BC CDC staff, and I give my profound thanks to everyone for their efforts. The job of analyzing all of the data and information received fell to the dedicated staff at my office, and they worked tirelessly to leave no stone unturned and ensure accuracy in reporting. And as always, my thanks to all of them. In particular, I would like to note the contributions of Sue Aberman, a dedicated healthcare professional and colleague of mine for over 20 years, who passed away before this report could be released. Her contributions were significant and highly valuable, and her counsel was welcomed. Now, this review is not the definitive review of COVID-19 in long-term care and assisted living. There are many aspects of the pandemic as it relates to those who live and work in assisted living and long-term care. My office recently examined the impact of pandemic visit restrictions on residents and family members. We still need to look at the overall impact of health outcomes. We need to look at the long-term impact on staff and facility operators, and undoubtedly there's things we haven't even imagined yet that we need to examine. I expect we will see these issues probed more deeply in the future as we get further through and hopefully on the other side of this pandemic. This review focused on the more narrow question of outbreaks and how can we control them. To complete this review, we looked at 487 sites of long-term care and assisted living. These are sites that were covered under the public health orders for the duration to date of the pandemic. The time frame that we looked at is a 1-year period of time. We examined from March 2020, so beginning of March 1st to the end of February 2021. And that's really what we're calling Wave 1 and Wave 2. So Wave 1 from March to September, Wave 2 from September to March. And we asked the questions, what are the factors that contribute to an outbreak? And then what are the factors that would contribute to an outbreak spreading? And based on these findings, what can we do to reduce the probability of an outbreak? And if there is an outbreak, to reduce the probability that that outbreak will spread. Over 100,000 records were examined. We looked at, over multiple years, we looked at 65,000 plus inter-eye assessment data to look for resident characteristics. We looked at 60,000 incident reports licensed from the Licensing Division of Health Authorities and the registrar at the Assisted Living Registry. We reviewed 6,500 survey results from staff who work in long-term care and assisted living. We had 356 long-term care and assisted living site reports with staffing and financial data, site-specific, for 2 years, the year prior to the pandemic and the year of the pandemic. We had 373 operators provide us with questionnaires detailing their outbreaks, their outbreak responses, and their overall impact of the pandemic on their particular site and their experience and perspective. We looked at direct care hour for all of our 298 publicly funded sites. We reviewed 487 Ministry of Health site records for both the long-term care and the registered living sites. We held 52 in-depth interviews with care homes that had experienced an outbreak. We received and reviewed over 100 documents from public health, such as orders, directives, guidance, policies, written responses, and we engaged in a focus group with physicians who had provided care through the pandemic in the long-term care setting. So what were our findings? Overall, in the review period, 210 sites experienced one or more COVID-19 outbreaks. Just a little under half, 100 of the sites, experienced more than one outbreak, for a total of 365 outbreaks. And what we can see is really, this is a story to a large extent about long-term care. 87% of the outbreaks were in our long-term care sites, and 13% were in our assisted living sites. We also see that 84% of the outbreaks were in the Lower Mainland, even though only 45% of sites are in the Lower Mainland. So we really did see a very disproportionate burden of outbreaks and of disease in the Lower Mainland. On the good news, 72% of outbreaks were contained to 4 or fewer cases. We consider that to be a contained outbreak. And 75%, gratefully, thankfully, experienced no fatalities. Of those that did experience fatalities, we know that the average of case fatality rate, so the percentage of people who contract COVID who would die from COVID during this pandemic, was 30%. Now, the first thing that you can observe here, this graph is basically showing us Wave 1 and Wave 2, and it's telling us two stories. First of all, it's clearly telling us that we saw the bulk of our cases in long-term care in Wave 2. The cases per 1,000 beds in long-term care is the gray line. And we're showing the community cases per 10,000 population in the blue line. So you can see that for the most part, as community transmission rises, as cases in the community rise, the cases per 1,000 beds in long-term care rises as well. And where you start to see them diverge at the end of the graph is where we're starting to see the introduction of the vaccine. So clearly its very powerful effects become evident when we're looking in at about, that's starting to diverge in about mid-January through to the end of February. And if you took that line out beyond this review period, you would see that divergence even more pronounced than you're seeing it in this graph. So let's talk about the characteristics of the outbreak. So one of the questions is, did who bring the virus into the facility make a difference in terms of the outbreak? So 76% of outbreaks sites reported identified a staff member as the first case, 22% with the resident as a first case, less than 1% were visitors. It's actually only one case, but so it's 0.02. And 2% could not identify who the first case was. So we analyzed that against the outbreaks, and what we found was that a facility was 4 times more likely to have a larger outbreak if its first case was a resident. It was 5 times more likely to have a larger outbreak if its first case was a night shift worker, and it was 1.5 times more likely to have a large outbreak if its first case was a nurse, an RN or an LPN. Now, for those of us who know how things work in long-term care and also how this virus is transmitted, these findings won't be surprising. So if the resident was the first detected case of COVID-19 in a facility, it is highly likely that the virus was in the facility transmitting before the first case was detected. Residents, for the most part, contracted the virus from staff, and staff contracted the virus either from other staff or from the resident. And so what you're seeing here is the effect of, to a large extent, asymptomatic staff, unaware that they are infected, and transmitting the virus to a resident. The resident is tested because they're beginning to show symptoms. The outbreak is declared. We come in with our control measures, but it's already spreading and incubating, and we are discovering a lot of cases very quickly at the beginning of that outbreak. Night workers and nurses, why you would see a higher probability of a large outbreak is because of how the staffing model works. So night shift workers are likely to work in multiple units and on multiple floors. You might have a ratio of 1 care aide to 25 residents in the day. That might go to 1 care aide for 100 residents or 50 residents in the night shift, and you're going from floor 2 to floor 3. And of course what you're doing is you're taking that infectious virus and you're taking it to multiple floors. So that is why if they were the first detected case, you are more likely to see the outbreak spread because it's already in multiple locations in the facility. And nursing staff, similar to night shift staff, are more likely to work in multiple areas of the facility, particularly registered nurses where there may only be 1 or 2 for a particular site, and they're on multiple floors and in multiple units. Notification of that first case actually was significant as well. 73% of contained outbreaks were notified by the person who tested positive, compared to 48% of the larger outbreaks. So that tells us that if I heard from the infected person, I had a much higher probability of containing that outbreak than if I heard from public health. This is also not unsurprising when you realize that you're going to hear about it fastest from the person who tests positive. They're going to call you right away, I've tested positive. As a facility operator, you know who that staff person is, you know where they worked, you can begin your outbreak protocols immediately. Public health could be contacting you hours or perhaps even a day later, and they're telling you that a staff person tested positive. They aren't identifying who that staff person is. And so the management of those outbreak protocols looks different, and we see that it did have an impact on whether an outbreak became a larger outbreak or remained a contained outbreak. Whoa, whoa, whoa. Hang on a second here. Okay. Testing protocols. So within the first 24 hours of the outbreak, which is the first test positive case, 5% of sites received direction to test all residents, but not all staff. 3% received direction to test all staff, but not all residents. 35%, so the plurality, received direction to test the staff and residents who were in close contact with that first case. 6% of sites received direction to test all staff and residents, and 12% of sites received no direction to test. For the most part, those will be sites that began as enhanced surveillance, where it was likely one staff person and there were assessments being made around how to implement outbreak protocols and whether or not to declare an outbreak. Within the first 96 hours of the first test positive case, so by the end of day 4, 22% of sites had received direction to test all staff, and 22% received direction to test all residents, and these are neither cumulative nor mutually exclusive. So what did we find in relation to outbreak size and testing? 91% of small outbreaks or contained outbreaks received some direction to test within the first 24 hours versus 79% of larger outbreaks. So, and this is when staff were the first case. So what that is telling us is that you were more likely to contain the outbreak if you received testing direction within the first 24 hours than if you did not. 10% of small outbreak sites reported receiving no direction to test versus 16% of larger outbreaks. So again, what that tells us is that those sites that received no direction to test were more likely to develop into larger outbreaks. And of the sites with no direction to test, 40% went on to develop into larger outbreaks. 51% of staff at small outbreaks reported that they were tested within the first 2 days versus 33% from larger outbreaks. So if you were a staff person tested within the first 48 hours, there was a more of those staff there was a greater probability that that outbreak would remain small and contained. Site level characteristics. So what did we see in our 485 sites? First of all, 61% of staff are regular and 39% are casual. And this did not vary much by site or by ownership model. So this is important for us to understand when we look at some other points, that approximately 4 out of 10 of staff in our long-term care assisted living settings are casual. And that's important when we talk about paid sick days, because while we have high, almost universal coverage of regular staff for paid sick days, almost nobody provides paid sick days for casual staff. And the sick days that are provided have quite a significant range, 2.5 days as the low to 18 days, which is the high, or what we call the industry standard. Overall, just over half of our sites contract for some services. Here we go. There wasn't a pattern by ownership in contracting for some services, anything, but when we looked at what type of services are contracted, we did see a pronounced pattern based on ownership. So health authority sites were the most likely to contract for housekeeping and food services and the least likely to contract for direct care services. They don't contract really for any direct care services. You see a small 2% for registered nurses, and that's really about what we refer to as agency nurses, which are often used in our more rural and remote areas where we have even more difficulties around registered nurse recruitment and retention. Sites that are for-profit and contracted to health authorities to provide services, so that is about a third of the sites, they were the most likely to contract out for direct care services. You can see 29% contracted for RN, 33% for the LPN, and 36% for care aides. That was the highest. And also their housekeeping and food, a little under half contract for housekeeping, and about 39% for food. The not-for-profits that are contracted to the health authority, and again, this is about another bucket of a third, they were more likely than the health authority, but less likely than the for-profits to contract for direct care services. 14% registered nurse, 22% LPN, 14% care aides, and you can see those numbers across the board. The fully private, so I should highlight that captured in all these data are those very few fully private long-term care sites in BC where there are no publicly subsidized residents. Their data are all to be taken with caution because they represent a very small number of sites. The sites themselves are very small, and they have a high proportion of co-located assisted living beds. So they overall look a bit different than really what we're seeing in the bulk of our sites that we analyzed. What we did find was that those sites that contracted for direct care services were more likely to have larger outbreaks. We looked at the distribution of direct care hours by staffing mix, and we looked at the 2 years. We looked at the pre-COVID year and the COVID year to see, did we distribute our care hours any differently? The answer is no. There was really no difference between the 2 fiscal years, but there was a marked pattern based on ownership of differences in terms of the allocation of these hours. And what we found was that health authority operated sites provided a much higher percentage of their care hours delivered by registered nurses than either for-profit or to a lesser degree, but still more than the not-for-profits. And it balances out because they provided fewer of their hours through care aides versus for-profits and not-for-profits. They tended to provide more LPN hours than both of the not-for-profits and for-profits as well. And in the fully private, the caveat there, because of their significant co-located assisted living beds, it's not unreasonable that you're going to see they have a higher percentage of care aides. So what we found in terms of outbreaks was that those sites with lower proportions of direct care hours delivered by registered nurses were more likely to experience a larger outbreak. That is not an unsurprising finding, because when you look at long-term care and assisted living sites, what you're seeing is that the people with the highest level of clinical training, assessment tools, assessment capabilities, are really found in your registered nursing staff. And on a day-to-day basis, it's not as apparent that those skills are needed. It's not an acute care setting. But when there's a crisis, and I don't think anybody will argue that this was a crisis, that's when you see the value of that additional layer of training, of expertise, of assessment that the registered nurse can bring to the site. And that came through clearly in the outbreak data. Paid sick leave. Almost all regular staff and very few casual staff receive paid sick leave. So I think it was 10% of casual staff receive paid sick leave. And the range, as I said before, was 2.5 days to 18 days. When you look at the days of paid sick leave, if we look at the 18 days, you find 100% of health authority operated sites provided the 18 days, 44% of not-for-profit sites provide 18 days, and 7% of for-profit sites provide 18 days. And then when you sort of look at all the other days, there's lots of ways to slice and dice it, but overall 51% of the for-profit sites and 22% of the not-for-profit sites provided 6 or fewer days of paid sick leave per year. And we did find, and perhaps this is the least surprising of the findings, that lower amounts of paid sick leave were much more likely to link to larger, and in particular our largest outbreaks. What were some of the other findings? Overtime. Overall, it increased by 63% and ranged from 27% to 178%. Sites that experienced a large outbreak increased overtime by 178%. There were 2.3 million hours of overtime delivered. I'm going to refer to it as last year, in the pandemic year. So think about the stress that that had on a system that wasn't adding additional bodies in order to provide that overtime. We didn't actually see an increase in paid sick leave, interestingly enough. Overall, in the year before, it was 5% of paid hours, and during the pandemic year, it was 5% of paid hours. That's not surprising, though, when you realize that really what's happening is there just aren't those paid sick days to use. And when you sort of triangulate that with the overtime and a few other, you realize that we really were seeing not an insignificant number of staff who were taking a financial burden by not being able to go to work for a variety of reasons related to COVID, either because they were ill and didn't want to go to work, they were isolating, and they didn't have access to paid sick leave. We also looked at associations between sites and previous inspections. So we looked at sites that had multiple inspections in the 2 years prior to the outbreak. So multiple inspections at a site are not a good thing. One inspection a year is what you should see. If you're seeing multiple inspections, it's because licensing officers are coming back to see if deficiencies that were identified in the inspection are addressed, or there are additional issues or complaints that require a further inspection. We did find, actually, that there was an association that those sites with previous outbreaks, or pardon me, with previous inspections were much more likely to be found in large outbreaks than contained outbreaks. We looked at an association with previous outbreaks. So before COVID-19, we had outbreaks in long-term care and outbreak protocols. Mostly those would be influenza, norovirus, other gastrointestinal illnesses. And so we looked at 3 years, actually, of the outbreak data to see what patterns, because you want to adjust in case there was a bad flu year in there. And actually we found that those sites that had an outbreak in one of the previous 3 years was significantly more likely to experience a larger outbreak. And we looked at the room configuration and found that the likelihood of having a larger outbreak was actually 24% greater in those sites with shared rooms. And the shared rooms could be semi-private, so 2 people, or sadly, we still have rooms with 3 or more people in them in the province. Staff experience, 6,500 staff answered this survey, and I really want to thank the staff that participated in this. As you would expect, extraordinary levels of stress and fatigue. This is absolutely an exhausted group of people out there. What I found interesting was their level of concern about infecting residents and their own family. Those concerns for others actually were greater than the concern they expressed for themselves, which I suppose is actually not unsurprising in somebody who chooses healthcare as a profession and career. The physical burden of PPE, this donning and doffing and wearing the mask all day, I think was underappreciated. So the intricacies of proper donning and doffing is not something we do on a day-to-day basis in long-term care. And in fact, the majority of staff don't practice donning and doffing as part of their regular practice in long-term care. So this was quite an extraordinary new burden to bear, and it was used when caring for COVID-19 positive residents. And the mask. Think about having to wear a mask every day for 8 hours for 365 days, and you're doing physical work. It was really, really tough physically, as well as all of the other emotional burdens that staff were made to bear. And the financial burden of unpaid sick leave, which I think we did also underappreciate. And a deep, deep concern for the impact of the pandemic restriction on residents. So this is a group of people who really do care about the people that they care for. So summary. Overall, the majority of outbreaks in BC were contained, and they didn't result in any deaths. Notwithstanding that, we tragically did experience outbreaks and tragically did experience deaths, and there are some learnings that we can take from that experience. Our approach to protecting the residents was based on on layers of protection. So keep infected people out, keep people masked if they are infected so they won't spread. The reliance on staff to remain at home if they felt unwell was challenging. 40% of staff reported that they came to work on one occasion or more during the pandemic when they weren't feeling well. Their main reason for coming was their concern of the burden their absence would have on their colleagues and residents, although the lack of being paid was also a concern for some. The necessary rigor for effective PPE practices was absolutely an underappreciated burden. Strong link between low levels of RN coverage, high COVID case counts, the practice of contracting for direct care staff and larger outbreaks, inconsistencies and frustrations from facility operators and staff around some of the outbreak management. So while the public health response was strong, all sites reported receiving somebody within 48 hours, most within 24 hours on site to help manage this outbreak. Some were frustrated by the different people and the changing direction that was received over the course of the outbreak. And frequent rapid tests in conjunction with our current PCR test protocol would be an effective strategy. So what are the recommendations? There are 7 of them. First of all, we need to expand paid sick leave. I think the evidence is pretty compelling. I know that on a province-wide basis, the public are being consulted or have just been consulted about paid sick leave to the population, to the working population at large. We need to examine what that needs to look like in these high-risk long-term care settings, and what are the number of days that need to be provided, and we need to figure out how we're going to cover that 40% of our workforce that's casual. Now, when we do that, we also need to have the staff who will be able to go to the site for those staff who remain away from the work site when they're not feeling well. So we need to continue efforts to increase the pool of staff. There are a lot of initiatives underway right now to recruit and train and mobilize more care aides. And we also need to look at increasing registered nursing, in particular the number of training or university seats that we have for nursing here in BC. We have waiting lists for, the good news is we do have people who want to be nurses. The bad news is we don't have a seat for them at one of our training universities at the moment. We need to increase the proportion of the registered nursing staff at the non-health authority sites. This will be a bit challenging because of the shortage within registered nursing that we are experiencing, but I think that we can start by establishing a baseline, a target, and then an expectation, and then measuring progress towards that. We need to increase the scope and frequency of testing. We have 2 testing tools now. We really only had 1 for most of this review period. We have our gold standard PCR and we have our rapid antigen tests. PCR is highly reliable. It can detect viral loads before people become infectious. The rapid test is very effective at detecting infectious people. So, as we know, the PCR has to go to the laboratory for testing assessment, and the rapid test can give you results quickly. So using both of them, particularly in outbreaks, that we could be rapid testing staff and residents daily. It's now only required to be a nasal swab, and then complementing that with the PCR test as indicated and required. We need to eliminate shared rooms. It is 10% of our sites have shared rooms. So it's not a lot, but it is significant, and not just from an infectious disease control perspective. I think we can all agree of the need for the dignity for people to have their own room, the privacy of their own room, and as much as possible with their attached bathroom. And vaccinations in long-term care and assisted living should be mandatory for staff, and booster shots should be provided to residents. And thankfully, actually, that recommendation has already been accepted or acted on, or implemented, I guess is the right word, by public health orders in the last few weeks. So that's it for the report. It's available on the website, and I am happy to answer any questions.
Thank you very much, Ms. Mackenzie. A reminder to reporters on the line, please press *1 to enter the queue. You may ask one question and one follow-up. For the first question, we will go to Moira Whiten from the Tyee. Please go ahead, Moira.
Hi, thank you so much for this report and your diligent work on all these issues. My first question is, it's very briefly mentioned about enhanced surveillance being a decision taken by some medical health officers in health authorities instead of declaring an outbreak. What is your assessment of the role enhanced surveillance may have played in outbreaks becoming larger than they needed to be, or just in general, whether that practice is a good thing in balance with not preemptively declaring an outbreak and sending residents into further isolation from their loved ones?
Thanks for the question. So I will highlight that enhanced surveillance is included in our 365 outbreaks. So our review was any test positive case or staff or resident constituted an outbreak, and we did include all of the, I think it's 178 some episodes of enhanced surveillance, most of which did not go on to develop into an outbreak, but some did. The practice, which started in about late October, early November, was really for many reasons, but I think the primary reason was to not shut the care home to family visitors, which would be required under the practices we had at the time if there was an outbreak. So absolutely, there are cases of enhanced surveillance that developed into large outbreaks. That didn't happen in the majority of cases, but in our single largest outbreak, that is what happened. Little Mountain started as enhanced surveillance and then developed into our largest outbreak. I think that if we adopted the practice of enhanced surveillance, but if what we did in response to that was to test staff and residents for COVID, it would be a highly, highly effective strategy. The challenge was that enhanced surveillance did not include testing. It was really looking for that next case, and then based on that, generally declaring an outbreak and the testing following from that. So I think there's two issues. There's the practice of enhanced surveillance versus an outbreak, and then the second question is what we do when we designate a site for enhanced surveillance. And I think if we do the testing, I think that is an effective approach, but that isn't the approach that we took.
Do you have a follow-up, Moira?
I do, thank you. In tandem with your last year report on the impact of visitors being and essential caregivers being shut out, the finding that only one visitor was identified as being the case zero of an outbreak, how do you think that decision was made, and do you hope that future outbreak protocols such as for norovirus or other gastro protocols will be updated, I suppose, to ensure that visitors and essential caregivers are protected even after the pandemic?
So, good question. One of the challenges, Moira, is that in COVID-19, these outbreaks lasted long times, and the people were separated for long periods of time. In outbreaks from before COVID-19, you'd be talking about a 1 week, maybe 10-day closure to family members, because we weren't really doing it to keep the virus out. That wasn't really why we closed in our pre-COVID years. We were doing it so we could focus on the residents that were living in the site. It was a different risk calculation with the COVID-19 outbreak, actually. But I do think, getting back to, we now have this rapid antigen test that can tell us if a person is infectious, and we have these highly, highly effective vaccines. And so I think we have to ask ourselves whether we actually are at a point where during an outbreak, a reasonable level of visitation can be maintained through a combination of the visitor is vaccinated and the visitor tests negative for COVID with a rapid test at the time of the visit. And I hope that we will be looking at that.
Thank you, Moira. Our next question comes from Zara Premjay at CBC. Please go ahead, Zara.
Hi there. Yes, I am. Thank you. Ms. Mackenzie, I wanted to ask you first off, what are your thoughts on a third vaccine for 65 plus across the board? So not just those in care, but for everyone 65 plus.
As I understand it, the evidence is still evolving. So what we're doing right now is we are giving the booster shots to the people in long-term care, the immunocompromised people. Now, there is logic to the next step would be looking at the booster shots for that same cohort that we focused on when we did long-term care, which is 80 plus, which two things, much more vulnerable to the virus and also much more likely to see that waning protection, right? So the waning protection is based on age and overall health and ability to mount this antibody response. So I do predict or hope that we will be continuing to look at, okay, what is the next group that needs the booster shot? The other thing to remember is the timing around this booster shot and that subtle difference between the protection if you had a 28-day or 21-day interval between your vaccines versus the 3 or 4 month interval. So the people who had the longer interval actually have higher, longer lasting protection and got the second shot later. So when we're starting to look at who is 6 months out from their second shot, I am hoping that we'll start to see more of these booster shots in the community. And certainly when you look at the data that are coming in now and around the fatalities from COVID-19, we are seeing the most compelling argument, obviously, is go get vaccinated. That's the most compelling evidence we're seeing from cases and hospitalizations now. But the next thing that we're seeing is that older adults in the community maybe would benefit from the booster shot as well.
Do you have a follow-up, Zara?
I do, thank you. So from your 7 recommendations, what do you see as the biggest and really the most immediate need in order to secure and keep care homes, assisted living safe in the event of, hopefully not, but another pandemic or another and more deadly wave of COVID-19? And what will you do to implement this change immediately?
Okay. So when I look at, first of all, everybody get vaccinated. Everybody in the community, everybody in the care home. Okay. Now, we know that that doesn't prevent an outbreak or transmission of the virus necessarily. We need to, the things we can do immediately, we can expand paid sick leave so that those staff who are displaying any symptoms of any infectious disease can stay home, and that those who need to isolate because of exposure can stay home. The next thing we need to do is look at our testing strategies in long-term care so that we are able to test and detect these staff and resident cases as quickly as possible and isolate staff away from the facility and isolate the residents within the facility.
Thank you. Our next question comes from Dirk Miser of the Canadian Press.
Hi, Seniors Advocate. I'm wondering, how close did BC, or did we at all get close to the similar situations that we saw occurring at the care facilities in Ontario and Quebec?
Yeah, it's a good question. And if you look in the report, you'll see we did a little, we compared ourselves with Ontario in part because that's really the only reliable data we can use right now. Ontario used the same one test case, one case would constitute an outbreak. And we focused on long-term care because the assisted living looks different in every province. So what we saw there was if you look at wave 1, BC did much better than Ontario. In Ontario, 20% of all their COVID-19 cases were in long-term care, and in BC it was 10%. Now, part of that is community transmission. You'll see that in the report, but that doesn't explain it all. The other thing were these measures we took quickly at the beginning of the pandemic. Dr. Henry, Minister Dix, didn't flinch when it came time to saying we need to do this now. They recognized the fragility. That clearly had an impact. By wave 2, Ontario was basically doing all those things that we did much earlier. And we had almost exactly the same experience. In wave 2, 5% of total COVID cases were in long-term care in BC, and 5% of total COVID cases were in 5% of long-term care in Ontario. So part of it is we took action sooner, part of it. We have a less overall fragmented health system in BC than they have in Ontario. And so that explains our wave 1 experience being so better, but by wave 2, we were about the same. I'm not sure if that answered the question.
Do you have a follow-up, Dirk?
Sure. Your report summarizes saying that residents in the care facilities were you found 3.5 times more likely to contract COVID and 33 times more likely to die of COVID. I'm just wondering if those numbers at all are getting any better. If you get a sense that those numbers are getting better, or where they're at right now.
They are getting better. So the case fatality rate was 30% during this review period. It's much lower now. I apologize. I meant to have that number anticipating this question. But when you look at, the proportion of cases and the number of deaths in long-term care, it's much, much, much lower now. That's the power of the vaccine. Because you have to remember, the vaccine is designed to protect against severe illness. So you may still get it, but you're not going to get as sick. And we're clearly seeing that in long-term care. As you know, we've had a little bit of an uptick in outbreaks in wave 4. Wave 3, it was pretty calm, but we're not seeing the severity of illness and fatalities that we saw in wave 1 as a proportion of those cases. So yes, it is getting much better.
Thank you. Our next caller is Mike Hager from Globe and Mail. Please go ahead.
Thanks for taking our questions. So you referenced Ontario as an analog for BC because they use the same criteria. But looking at Quebec, they had tons of deaths during the first wave, but they were unable to contain it. During the second wave, they implemented stricter mask requirements, infection prevention control, and just went on a hiring blitz that summer. Why did BC do so poorly? Nearly 90% of all the deaths came in the second wave. Why did it fail in the second wave?
That is a good question. And as I say, clearly our wave 1 experience, part of that was due to our overall lower community transmission, which we did not see in wave 2. In wave 2, even though all the numbers were higher, actually the proportion was still lower. So in wave 1, 10% of our cases were in long-term care, and in wave 2, it was 5% of our cases. Now, when we look at the review and we say, okay, what could we do that would reduce those number of cases? That's where we're saying, provide more paid sick leave to your staff so that they will stay home when they are sick. Increase the presence of registered nurses on your site so that you have that leadership and clinical expertise to control that outbreak. Reduce shared rooms because people in shared rooms, if one person is positive, clearly a higher probability that the other person will also test positive. And then testing. So get in there at the beginning, test everybody, repeat test frequently, and we now have the rapid antigen test to add to the toolbox. We can't have it substitute in totality for the PCR test, but we can use them in a very complementary way. One of the big things that happened in January was the rapid antigen test was approved for use as a nasal swab only. And that is significant when you're looking at the care facility sites and the burden on staff and the expertise required to do a full nasal pharyngeal swab, which is what the PCR test requires, was, I think, frustrating the ability to fully implement the rapid antigen test. That roadblock is gone now. So they are very easy to use, and they are arguably not as sensitive as the PCR test in that they don't pick the virus up as early in the viral load. But if you are shedding a lot of virus and infectious, it is highly, highly sensitive to picking up the disease.
Do you have a follow-up, Mike?
Always. Thank you. Sorry, so you didn't really touch on what operators told you about why they didn't staff up in between the first and second wave. Did they say anything there? And then also wondering for your second recommendation about more direct care, how can you do that in this sector, especially, you know, for operators that are trying to make a profit? We just got an email yesterday from someone whose mom broke their tibia in an IMO long-term care home. Care is not where it needs to be, and the pandemic kind of really highlighted that. You've done so in past reports. How do you expect the sector, particularly the for-profit part of the sector, to deliver those care hours?
Okay, so I'll try to answer your first question, which was about staffing up. It is a good question. I think that it's possible that when we were looking at various potential second waves, that we underestimated the degree to which it was going to overwhelm the long-term care system, particularly in the Lower Mainland. And to be fair, there was movement on the initiative to train and mobilize more staff. It can't happen overnight. So I think it was recognized that more staff were needed. You're seeing that reflected in these extraordinary levels of overtime. So you have an exhausted labor force because, yes, we didn't increase the bodies a lot, but we increased the demand on those bodies exponentially. And so we're going to have to look at how we get more bodies in, because that level of overtime is not sustainable, irrespective of the financial impacts, just the human impact. And then your next question about decreasing the contracting for direct care. You know, a couple of things have happened there. First of all, the wage leveling. And once an operator is paying, for want of a better term, the industry standard wage levels, a lot of the benefits for contracting disappear or dissipate. And so if we maintain that wage leveling on a go-forward basis, I think we will find that over time, operators will shift to employing people directly, because there won't be the margins, if you will, to be able to pay a contractor when these industry standard wages or the wage leveling wages have to be paid. So I believe we should maintain that ongoing. I've, as you know, spoken about that frequently in the past. And I think if we do that, it's going to solve another problem as well, which is I think we will actually see a significant decrease in contracting for direct care.
Thank you. Our next question comes from Mary Griffin at Czech. Please go ahead, Mary.
Oh, hi. Thank you so much for taking my call. And just following up on the for-profit facility, it just strikes me with residents of long-term care facilities making up the bulk of the deaths during this pandemic. It just seems that there could have been stronger language, or, you know, is there any, and I'm not saying guilt, but more pointed language in saying, look, you know, this industry could have done better, you know, and maybe it's time for a reshifting of this industry. Should there be for-profit when you're caring for society's most vulnerable, who have paid with their lives as a result of how many of these facilities have been run?
It's a good question, Mary, and as I think we all know, there's lots of discussion and debate on the topic out there. What we did in this review, and there's lots in the report about the distribution of cases on a case basis, and it's very difficult to measure these things completely accurately because everything is not equal everywhere. But on balance, on the rate per 1,000 beds in the we did see more in the contracted sector. I think what I'm trying to do with this report is not focus the conversation around change the model and eliminate for-profit, and those are different debates. This review is focused on what are the elements that we need to change. So the question is, what is it about those sites that's different from the health authority sites that led to larger outbreaks? And let's fix that. So let's start by increasing paid sick leave, increasing registered nurses, decreasing contracting for direct care, and eliminating shared rooms. Although the vast majority of shared rooms, pretty much almost all the 3 to a room, are in health authority sites. But that's what we can do now that will help tomorrow and next year and the year after. This bigger debate around how do we provide, what model works best, I think is a legitimate conversation to have, but I don't want it to overshadow or overwhelm the fact that there are some things that we can do right now that will make those for-profit sites more like owned and operated sites. And that's what we that's what I want to focus on most immediately.
Do you have a follow-up, Mary?
Yeah, just for the families, can you assure them that going forward now that for the most part that their loved ones who are in these facilities for profit and those operated by health authorities are for the most part safe, that do you have assurances that all of your recommendations will be put into practice and that they can be sure that their family members are going to be safer going forward in the future?
Well, sadly, I can't guarantee, other than recommendation number 7 around vaccinations. These recommendations have been provided to the minister and the ministry, and it is my hope that they will be implemented. I don't have the power to order it, so I can't guarantee that. What I would say is that we've made all sites more safe than they were at the beginning of the pandemic from some of the things that we've learned. And we've made a few course corrections, and arguably we need to make a few more. I would say that the confidence that your loved one is well cared for, I can appreciate is at the forefront of the thoughts and anxieties, frankly, of many family members out there. And it is constant vigilance to provide that assurance. That vigilance starts first and foremost at the level where family members, if they don't believe that their loved one is being cared for properly, they need to report that. They need to talk to their health authority, they need to talk to their PCQO, Patient Care Quality Office, and they need to talk to licensing so that it can go in there and fix. And we need to continue the kinds of monitoring that we're doing. I think there is a legitimate discussion for another day. We've identified it in the report about multiple inspections and what that is, whether we want to look at our regulatory regime and put a little more incentive into compliance than we have right now, because we did see that link to larger outbreaks and inevitably to other things. So, that's, I'm very, very appreciative that we're giving booster shots. I think we were beginning to see the effect of the waning vaccine. We're going in and giving those booster shots now. So hopefully we will maintain that much higher level of safety in our care homes going forward than we were able to achieve at certain points in the pandemic.
Our next question comes from Lisa Cordasco, the Vancouver Sun. Go ahead, Lisa.
Thank you. Good morning, Ms. Mackenzie. I noticed that there aren't any specific recommendations around PPE, despite the fact that it seems like surgical masks don't seem quite adequate anymore now that we know more about the airborne nature of this disease. And then there were problems of donning and doffing the equipment. But all of this is still in effect.
It's a good question. It's not an explicit recommendation, Lisa, but I did reference it in the report. So, and the reference I made that I think, given what we now know about it, it being the COVID-19 virus, I think it is not unreasonable to re-examine whether, when there is an outbreak, we should be using the N95 respirators. That's when the effectiveness of that additional protection from the N95 respirator would be welcome. I think there are continued studies about that effectiveness, and there may or may not even be some happening in BC. So it is an N95 respirator is a higher level of protection than a surgical mask. Now, they are to be fit tested. So there are all of the logistical challenges around that. They are, for some people, much more restrictive and uncomfortable to wear than the surgical mask. But if you look at, that's what's needed either when caring for COVID-positive residents or when there's an outbreak, you can contain quite a bit the issue around supply, and you can contain quite a bit the issue around the discomfort, because you're only going to be doing it either for that period of time of direct care to the COVID-positive resident or for the period of the outbreak. And the outbreaks are getting shorter in duration now.
Do you have a follow-up, Lisa?
Yes, thank you. I'm wondering, why is there an issue or a problem with contracting out professionals like RNs or LPNs?
Well, it's a good question. Why did we see that association? And it could be that there's multiple things happening. So when the RN is contracted, part of it is the cohesiveness of your care team is, in some cases, not all, compromised when the care aides work for this company and the registered nurse works for this company and food services work for that company, and they might have multiple different directors and direction. And so I think that is part of what we were seeing in that pattern, that giving consistent and cohesive direction is important. The contact tracing. Most of our testing strategies were based on, do you show symptoms and are you a close contact? And that was contact tracing. The ability to contact people, to do all of that, was frustrated by multiple different employee lists and multiple different bureaucracies. And that is possibly one reason why we're seeing it reflected. That wasn't the case in all sites that contract for direct care, but it certainly was the case in some.
All right, thank you. Our next question comes from Robert Buffum from CTV. Please go ahead, Robert.
Oh, hi. It's a question that's been essentially asked before, but I'm just wondering if 40% of staff reported that they went to work feeling unwell at least once, and half of them were motivated for financial reasons. Where do you rank? How important is having increased sick pay on the list of recommendations? Is it number one?
I think it is. Number one. I think for COVID and a whole other host of reasons, we've got to have people who work in long-term care and assisted living stay home when they don't feel well. Even with that, we've got to battle this issue of asymptomatic transmission. So even with increased paid sick leave, we would still experience staff who are infectious but don't know it because they're not displaying symptoms. But we would be lowering and lowering and lowering the probability. Now, even the mildest symptoms. People didn't go to, there isn't anybody out there, I don't believe, who thought they had COVID and went to work. These are people who didn't feel well, but they didn't think it was COVID. And so and for a whole variety of reasons, they continued to go to work. And we did see that in larger outbreaks linked to higher proportions of staff that reported coming to work at least once a year when they didn't feel well. So, you know, and it's why there's the two recommendations, not just increase sick leave, but you got to increase the pool of care aides, because remember that the reason that most people ticked was the burden their absence would have on their coworkers and the residents. So we've got to have the person to send in to substitute for the person who's staying home. And those sort of go hand in glove. But absolutely, you know, aside from the public health perspective, there's just this overall fairness perspective, which is this unfair financial burden that many care home staff bore by having to stay home and not be paid.
Do you have a follow-up question, Robert?
I do. I guess I'm wondering, what's your take on the data that just one outbreak was caused by a visitor? Do you see that as support for the restrictions on visitors in November of 2020, or that we're talking about the importance of being able to visit their loved ones and, you know, the negative impact on that not happening? And said, look, we're going to be extra safe. We're not going in there unless we know that we're safe. Does the low number of outbreaks caused by visitors speak to maybe it was a mistake to not allow more visitors in earlier?
Well, as you know, I have spoken on that and reported on the visit restrictions in long-term care, and I think we could have approached it a bit differently. Going forward, we now have two powerful tools, the vaccine and the rapid antigen testing. And I think that using those two tools, we can decrease the probability that a visitor will be infectious and bring COVID-19 into the care home to a negligible amount, and reflect back on how significant it is for residents to be able to stay connected to their family members. So hopefully going forward, we're not, if somehow something happens and we get a wave 4 spike in outbreaks in long-term care, we're still able to maintain that with the tools that those essential visits with the tools that we have.
And our final question for the day is from Jane Said from North Shore News. Please go ahead, Jane.
Hi, I just want to ask you a question about some of the earliest outbreaks that you saw, the Lynn Valley Care Center in North Vancouver being one of them. I'm just wondering, what are some of the things that we were able to learn from the way those outbreaks were handled going forward, and what were some of the things that we didn't learn or didn't pick up on as well as we should have that contributed to the later outbreaks?
Good question. So I think first of all, it was a horrific outbreak. The residents, their family members, they had an unimaginable experience. And the fact that some good came of it because we learned some things we could apply to other outbreaks will be a comfort to some, but not all. That outbreak taught us a few things rather quickly. Because of that outbreak, we very quickly mobilized these rapid response teams. That is because of the chaos that ensued and when the outbreak was declared, when public health went in, they realized very quickly we've got to get in here fast and stabilize these outbreaks quickly. So that happened fairly shortly after Lynn Valley. That outbreak was a site where there were 3 different contractors to provide direct care services, food services, and housekeeping. And because of that, it became very obvious that this is a problem, and led to decisions around wage leveling, bringing under staff under control, some way under control of the provincial health officer, and the single site order, that the staff cannot be going from site to site. So that was a positive learning from that as well. The impact on staff around, they simply did not show up for work, the fear factor when the outbreak happened, and we saw less of that as we got further into the pandemic, but certainly at the beginning, some staff just fearful and not going to work, and that there was a horrific impact of that at Lynn Valley, and mostly it was the residents and the family members of those residents who bore the brunt of that. What I think we still needed to recalibrate a bit was around our testing strategy. So when Lynn Valley outbreak occurred, we were still believing two things: that you couldn't spread the virus until you showed symptoms, and we weren't as confident in the PCR test as we later became, to be able to pick up test positive people earlier in the infection. As we learned more about that, I think we could have amped things up a bit more than we did, because that was the other lesson out of Lynn Valley was it will spread quickly. You need to get the staff out who are infected, and you need to be wearing your full contact precautions, PPE, when dealing with COVID positive residents. And then this issue of cohorting, where it's there's arguments for it, against it, but certainly looking at that quickly were lessons that we learned from that outbreak.
Do you have a follow-up, Jane?
Yes, I note that you refer to the different contractors that were on site at that facility, and I guess other similar situations where there's multiple contractors as contributing to problems in contact tracing, in notifying people what was going on, and just generally getting a handle on the situation. I'm wondering if you can talk about that a little bit. I know you've touched on it a little bit already.
Well, we've made some gain because of some of the things we've done. We've unified the workforce a little bit more because of the single site order and the wage leveling. There are more cohesive lists of everybody who's working and where they're working. And going forward, we need to maintain that. And I think for care aides and for the nursing staff, that can be achieved through the registry and through the college. So every care aide and every nurse has a number, a registration number. They have to renew that every year. And every work site that employs those people could be required to submit to their registry or their college the fact that the person with that number is working at that site. And that would allow us to quickly mobilize. More challenging with housekeeping and food services staff, because they're not regulated care providers or unregulated care providers. They're not registered either. But I think looking at that going forward, we could. I also, as I said in the presentation, I think that if we maintain the wage leveling, we may find this issue of contracting for direct care takes care of itself. Because as an operator, my benefit from contracting for direct care is significantly dissipated by the wage leveling. It will cost me more to contract for direct care services than to employ people directly myself. So, you know, I am hopeful that decisions will be made around wage leveling and the permanency of it, and then we will see what falls from that.
Thank you, Ms. Mackenzie. Those are all the questions we have. I want to thank everyone for joining us today.
Thank you very much.